شكرا دكتور كريم for this excellent presentation. طبعا حجتك قوية جدا، لكن عندنا الرجل المهام الصعبة الدكتور سيد فرج. أنا عارف إن هو هيرد رد قوي جدا. هو يعني I would say there is nothing absolute in medicine. مفيش drug magic هينفع for 100% من العيانين. ونسمع بقى الدكتور سيد فرج يقول ايه.
First of all, I'd like to thank Professor Hassanin for this kind invitation, and I'd like to congratulate him and the CV report for this continuous success of the CME activities, especially in one of the important topics. And I think heart failure is now the topic of the every hour. There is innovations in the treatment, there is new evidences, and there is a debate, and I think it is not a real debate. And I would like not to leave you after this debate confused. Our aim, me and Karim, to let you directed evidently to the right management. As I asked by Professor Mahmoud Hassanin to take the contra of the question, which is, should SGL2 inhibitor and ARNI now be considered first-line treatment in heart failure with reduced ejection fraction? Let's first know or dive through the current evidence. The current evidence came from the European Society of Heart Failure, Society of Cardiology Guidelines of Heart Failure, which stated class 1 indication that sacubitril valsartan is recommended as a replacement for ACE or ARBs to further reduce the risk of heart failure hospitalization and this on those ambulatory patients. Yes, I know that Professor Karim present a lot of evidence that we have to initiate early, and the earlier the better. But now we still have an evidence in ECC that it is class 1 to use ACE, ARB, and if the patient is still symptomatic to replace with ARNI. This is the current recommendation from the European Society of Cardiology. From an important consensus, which came a few months ago, that the expert decision pathway for heart failure with reduced ejection fraction treatment optimization, I'd like to remind you with the stages of the heart failure, because it is important to know that heart failure stage C, and that is what we mean in this pathway, and this is latest pathway, those patients with previous or current symptoms of heart failure in the context of underlying structural heart problem, but managed with medical treatment. So those are the patients who were brought on this pathway of the consensus, not the stage A, not the stage B. One of the important statements in this pathway is that for patients with newly diagnosed stage C heart failure with reduced ejection fraction, a beta blocker and an angiotensin converting enzyme inhibitor ACE or ARB, ARNI should be started in any order. So we still have the evidence for ACE, ARBs, and ARNI the same together to start with from the latest evidence, which is the expert decision pathway. Why I'm mentioning and stressing on this point? Because sometimes we have to use the evidence weapons in our hands. Not all the patients we can prescribe for them ARNI, maybe because of cost, maybe because of unavailability. We have a lot of villages out of the reach of this drug prescribed by physician there. So they have the evidence for ACE or ARB to start with. The second important statement is after, and I'd like here to underline after initiation of beta blocker and angiotensin antagonist, addition of an aldosterone antagonist should be considered with a close monitoring of electrolytes. Then sodium glucose co-transporter should also be considered. Yes, we have the 4 pillars for initiation of the heart failure with reduced ejection fraction, but I think this is more practical pathway which is stated by the American College of Cardiology. Why? Because sometimes you need some time. To initiate first the beta blocker, ACE or ARB or ARNI, to see the hemodynamic effect, to see the electrolyte effect, then you can start with the SGLT2 inhibitor after those drugs. So here is more practical pathway is beta blocker, RAS blockade either by ACE, ARB, or ARNI is mandatory. Then we have to add the MRA. Then we have to add the SGLT2 inhibitor for those patients with heart failure with reduced ejection fraction, NIHA class 2 to 4. And I think from practical point of view, in most of our patients, when we start with the beta blocker and RAS blockade and up titrating the doses with sometimes a need of diuretic, most of the patients improving. Then there is some need after that to add the SGLT2 inhibitors. The last important statement from this pathway is the socioeconomic barriers. So here they did not neglect the socioeconomic barriers. The socioeconomic barriers pose a major barrier to use the ARNI, SGLT2 inhibitors, and ivabradine because of cost. Even in the richest country in the world, in the USA, they are still suffering from the cost for using all those drugs altogether. So they have to prioritize some of the drug over the other. And if we look here, they may include virtual care of visiting. In these cases, financially feasible options should be considered. We may start with ARNI first, and then we add SGLT2 inhibitor if the cost allow. So they are considering here the cost of the patient. Why? Because if you burden the patient with all those costly drugs, you may lose the adherence and the compliance for the patient. And this is a very important point. And from the practical point of view, sometimes we clustering the patient with all those molecules, and then we miss the patient because of the cost, and the patient even didn't take any of them. So please, we have to prioritize and to tailor according to the socioeconomic and also the clinical status of the patient. And this is evidenced by the consensus 2021 from the American College of Cardiology. And here again, this is important pathway for stage C treatment, ARNI, ACE, or ARB. And they give, of course, a preference for ARNI. But again, they put all together in the same line. So we can start with ACE, ARB, or ARNI. This is evidenced. With a preference of ARNI? Yes, with a preference of ARNI. The second point is for patients meeting the eGFR criteria, we may add SGLT2 inhibitors. And this will take us again to the second point I mentioned in the consensus. We have to wait to see the renal status, to see the electrolyte status, to see the hemodynamic status. Then we can add, if the eGFR meeting the criteria, the SGLT2 inhibitors, and if the symptomatology of the patient need to add another drug like SGLT2 inhibitor. And this is also important from important algorithm from one of the publication of the American Heart Association journal, that the adjustment of the concomitant therapy. In heart failure therapies, we have to discontinue non-evidence treated heart failure therapy to minimize polypharmacotherapy. This is very important also. Consider measuring the digoxin level, sometimes we need. Adjust loop diuretics if needed. And this is important. Why? Because sometimes when we combine the loop diuretics with the SGLT2 inhibitors, the patient is over-deloaded. And this over-deloading may lead to reduction of intravascular compartment volume and leads to aggravation of his hemodynamic instability and hypotension. So it is important to adjust the loop diuretic with the SGLT2 inhibitor. So as Professor Karim said, it is one of the 4 pillars, but we have to use it properly not to miss its benefit. A practical consideration for the use of sodium glucose cotransporter inhibitors in heart failure, which is also published recently in the Circulation Heart Failure Journal in February 2020, and they asked a very important question: ARNI or SGLT2? If we back again to the cost, this question is important. Given that the sacubitril valsartan has a class 1 guidelines recommendations for patients with heart failure with reduced ejection fraction, its preferential use may be considered over the SGLT2 inhibitors, because we have a more strong evidence for ARNI, so it is give a priority for the ARNI to start with if we are asked about ARNI or SGLT2 first. And we come to the prestigious guidelines which came always from the Canadian Cardiovascular Society. Let us read this recommendation, which is 2021. We recommend that ARNI be used in a place of ACE or ARB in patients with HFrEF who remain symptomatic despite treatment with appropriate doses of guideline-derived medical therapy to decrease cardiovascular death, heart failure, hospitalization, and symptoms. So, ACE and ARB still as a first line of therapy in the latest guideline from the Canadian Cardiovascular Society, and to be replaced with ARNI if the patient is still symptomatic. And I'm talking here about the ambulatory patients. This is the 4 pillars: ARNI, ACE or ARB in the same line again. Beta blocker, MRA, SGLT2 inhibitors. The recommendation here from the Canadian guideline, moderate quality evidence. So we still need more evidence to support the use of all the those 4 pillars at the same time. Yes, we have to use them, but at the same time, this here is the question. And a few weeks ago, one important trial came to the stage, which is the angiotensin receptor nebulizer inhibitor ARNI following acute myocardial infarction, Paradise MI trial. In the Paradise MI trial, which include a lot of groups of patients who aged more than 70 with atrial fibrillation, ejection fraction less than 30, diabetic, prior MI, STEMI without reperfusion. And they exclude, of course, prior heart failure and clinical instability. And the primary endpoint was cardiovascular death, heart failure, hospitalization, and outpatient development of heart failure. Look at the result. The result here with ramipril, that there is no significant difference between ramipril and sacubitril valsartan as regard the primary outcome in patients post myocardial infarction, and they came to the summary and conclusion that in vigorously managed enhanced risk MI population compared to active therapy with ramipril, sacubitril valsartan did not result in significantly lower rate of cardiovascular death, heart failure, hospitalization, but, and I'd like here to underline but, the safety and tolerability of sacubitril valsartan in this AMI population was comparable to ACE inhibitors. So there is a place for those drugs to be used if needed, but there is again the same line of indication, and maybe here in post-MI patient a superiority for ACE or especially ACE in post-myocardial infarction. Finally, my take-home messages. Yes, we have enough evidence come from a lot of trials and came also from the latest consensus of the American College of Cardiology for using the 4 pillars, but with taking in consideration some of the hemodynamic effects and also the renal status of the patients during initiation and electrolyte monitoring. But we should have enough wisdom for tailoring those drugs, especially the clinical status, as I mentioned, and also the socioeconomic status of the patient, which is very important during tailoring and making a strategy for treatment of any patients. And finally, of course, any debate should leave you much more clarified, not badly confused, and I hope that me and Dr. Karim did so, and thank you for your attention.
شكرا.